This study will address adhering to the advice to avoid alcohol consumption when diagnosed with hepatitis C. This video will focus on the biostatistical data and the evaluation of healthcare delivery to the hepatitis C patient who drinks alcohol, despite the advice given by their healthcare provider to avoid consuming alcoholic beverages. Infection with the hepatitis C virus has become a leading cause of scarring of the liver and cirrhosis within the United States. Hepatitis C virus-related cirrhosis is a major cause of death. Although it develops slowly and occurs only in approximately 1/3 of hepatitis C infected patients, alcohol can exacerbate the hepatitis C infection and the associated liver damage caused by oxidative stress and promoting fibrosis, thereby accelerating disease progression to cirrhosis. Furthermore, alcohol may exacerbate the side effects associated with current antiviral treatment of hepatitis C infection and impair the body's immune defense against the virus. Of the hepatitis C infected people who do not consume alcohol, only a majority progress to severe liver disease and require antiviral treatment. Because alcohol potentiates the fibrosis and cancer-inducing actions of hepatitis C virus, alcoholics are particularly vulnerable to hepatitis C infection and in most need of treatment. What is hepatitis? Hepatitis is an inflammation of the liver that is characterized by jaundice, liver enlargement, abdominal and gastric discomfort, abnormal liver function, and other symptoms. Although in many patients the diseased liver is able to regenerate its tissues and retain its functions, severe hepatitis may progress to scarring of the liver tissue, cirrhosis, liver cancer, hepatocellular carcinomas, and chronic liver dysfunction. Hepatitis can have numerous causes such as oxidative effects due to excessive alcohol consumption or infection by certain bacterial viruses. One common cause of hepatitis is infection with one of several types of viruses, hepatitis A, B, or C. With the development of the new diagnostic tools, infection with the hepatitis C virus has received increasing attention in recent years. In the United States, the number of deaths caused by hepatitis C virus is increasing and may approach or even surpass the number of deaths from AIDS in the next few years. Hepatitis C virus infection is becoming a leading cause of cirrhosis, liver failure, and hepatocellular carcinoma, with incidence and prevalence rates of those complications highest among non-white, racial ethnic groups. Lifestyle and socioeconomic factors have been implicated in these ethnic and racial differences. In addition to genetic factors in the infected person, 3 independent factors are associated with the increased rate of disease progression to those life-threatening consequences. These factors include daily alcohol consumption of 50 grams or more, which is the equivalent of 3 standard drinks, age at infection of more than 40 years, and male gender have a greater influence on fibrosis progression in hepatitis C infection than the virus itself. Early studies have reported that hepatitis C infection was particularly common among alcoholics, affecting 35% of alcohol-dependent people. This study will examine alcohol consumption within the context of hepatitis C. The purpose of this study is to know about how non-problematic drinkers respond to advice to reduce alcohol consumption as part of disease management for hepatitis C, because hepatitis C is contraindicated in the presence of alcoholism. In this study, we examined patients' reports of drinking behavior after being diagnosed with chronic hepatitis C. Reducing consumption or abstaining from alcohol is recommended for many medical treatments and non-alcoholic related conditions, such as severe diabetes and pancreatitis. but most research on patient responses to medical advice to stop drinking has focused on problem drinkers whose denial, physical dependence, and withdrawal are major impediments to alcohol reduction. Little is known about how non-problematic patients respond to medical advice to reduce drinking as part of their management of the disease, not related to alcohol consumption. This study's responses to advice to curtail alcohol consumption after diagnosis of chronic hepatitis C has been identified in the non-problematic drinker will be examined. Although few studies have examined alcohol reduction in medical illnesses among non-problematic drinkers, researchers have demonstrated that patients are less likely to adhere to recommendations for long-term behavioral change than they are to prescribed medication regimens. Behavioral changes where benefits are not immediately obvious appear especially difficult for patients who drink and have hepatitis C. This study will not only focus on those aspects, but focus on those aspects for two reasons. First, hepatitis C infection is a prototypical of non-alcoholic related conditions for which drinking is contraindicated. Second, increasing levels of self-reported alcohol consumption prior to chronic hepatitis C diagnosis has been associated with elevations in serum viral titers and hepatic fibrosis scores. The methods for this study reported the results of a 2-year qualitative investigation for post-diagnosis of alcohol consumption among non-problematic drinkers diagnosed with hepatitis C. The data generated through semi-structured interviews from 42 hepatitis C positive patients was obtained. Recruitment was obtained in 2 ways. First, by emergency room department visits for positive hepatitis C patients were recruited, and second, by patients who were established from a GI clinician's office to help carry out this study. Eligible respondents were recruited through both strategies, and associated with non-problematic drinkers were defined. The scores associated with non-problematic drinkers were defined as 10 or less on the Alcohol Use Disorders Identification Test. The sampling grid design was implemented to ensure variability of gender, race, and ethnicity, African American, Hispanic, and non-white informants. The level of alcohol use was implemented on the audit score. Scores were obtained between 0 and 7 and between 8 and 10. Respondents ranged from 37 to 75 years of age. The mean was 50.3 years, and the standard deviation was 8.1. 69% were men, and the mean level of education was 12 years for the highest grade completed. The standard deviation was 2.3. Of the respondents, 39% identified themselves of African American descent, 27% as Hispanic, and 34% as Caucasian. The mean time since the diagnosis for the hepatitis C was 7.8, with a standard deviation of 6.6. The audit scores ranged from 0 to 10 at the time of recruitment. The mean was 4.8, and the standard deviation was 3.6. 10 respondents were noted to have been diagnosed within the past 2 years, with the remaining having been diagnosed with hepatitis C 6 years prior to the study. The interview protocol and the guidelines consisted of 12 questions. The 12 questions included the person's knowledge about the disease, experience and treatment management for hepatitis C with antiviral therapy. Interviews were conducted in a structural probe manner. The results of the study indicated adherence. Adherence involved strict compliance with advice not to drink. There were 2 types of adherence that were identified. One was quit immediately after diagnosis. 21 of the respondents were associated with this. 2 quit after the delay. Some informants continued drinking after diagnosis, but eventually quit, attributing their decision to stop drinking to 4 factors: disease symptoms or complications, negative reactions to alcohol, treatment-related issues, and reasons not related to hepatitis C virus. The overall conclusion was patients do adhere to the advice of clinicians when told not to drink in the presence of hepatitis C. This concludes the biostatistical study for biostats.